It's my pleasure to introduce our next guest, a highly skilled cardiologist who is board certified in internal medicine, cardiology, and interventional cardiology. Dr. Dinesh Sharma completed his residency in internal medicine in Case Western Reserve Metro Health Medical Center in Cleveland, Ohio. He then continued his training at Case Western, where he completed a fellowship in cardiovascular disease. Further specialization in his field, he pursued additional fellowship training in interventional cardiology at Beaumont Hospital in Royal Oak, Michigan, followed by a structural cardiology fellowship at Buffalo General Medical Center, University at Buffalo, New York. A fun fact about Dr. Sharma: both of his parents are nurses, which played a significant role in inspiring his medical career. He's deeply committed to building trusting relationships with his patients, believing that trust is essential in guiding them through their treatment journey. He approaches healthcare with a personal touch, envisioning each patient as a family member and discussing their treatment options as if they were an aunt or an uncle. Dr. Sharma has been practicing for 5 years and has been a valued member of Desert Cardiology for the past year, and he's one of my favorites. Please join me in welcoming Dr. Dinesh Sharma. Dr. Sharma couldn't make it in person today, so he's going to be on Zoom.
Thank you, Lisa, for that introduction. And thank you for allowing me to do this on Zoom. I appreciate it. I had to kind of run across the country for some family members, so I really appreciate it, and thank you. So today I'm going to be talking about PFOs, also known as patent foramen ovale, and the understanding of it, why it's physiologically significant, the diagnosis of how we make that call, and interventional approaches to it. Unfortunately, I have no financial disclosures. So what is a PFO? A PFO is simply a communication between the right and left atrium of the heart. And in order to understand this, it is a congenital condition where there's an opening between that. As you can see on the left-hand side, this is a normal heart where there's no opening between the right side and the left atrium. And over here on the right side, you see that there is an opening between the right and the left atria due to incomplete closure of the foramen ovale after birth. So why do we have this opening in the first place? Well, it actually plays a vital role for fetal circulation. We'll go step by step here. So there's two things different about fetal circulation than there are about adult circulation. One is that when you have blood here coming from the placenta, it's oxygenated. Whereas when you have blood returning to your heart, it's usually deoxygenated. It's used up by all of our organs, and when it comes back, it's usually marked as blue rather than the red that we have here. But for fetal circulation, it is oxygenated, it is red. For adults, usually what would happen is you see it come up to this right atrium. And then for adults, it would go down to the right ventricle and then go to your lungs to get oxygenated. Well, for fetal circulation, those lungs haven't been developed. So because they haven't been developed, there's an increased pressure system on the right side of your heart. I like to differentiate this as the right side is usually pulmonary circulation, left side is systemic circulation. And we'll go through the differences in that. But when you have increased resistance, because your lungs aren't developed, then the blood flow just takes the path of least resistance. And in this situation, the path of least resistance would be from this right atrium to this left atrium. And the only way to do that is because you have this communication in our fetal circulation to begin with. So all this oxygenated blood, instead of dropping down here, goes across into the systemic circulation and then supplies the fetus. And that fetus is supplied with all oxygenated blood, and that's how they get the blood. Now, when the fetus finally takes their first breath, they're born, and baby takes its first breath, all of a sudden the pressures drop in the lungs. So now you've had a huge pressure drop on the right side, and you have this big pressure buildup on the left, because while their pressure drops on the right, they have a big pressure buildup on the left, the systemic circulation. So when that happens, usually right here, as you see, this would close off, because all of a sudden this has high pressure, this has low. Let me just go on to the next slide. And then that normally seals off there. Just another slide kind of demonstrating that it normally seals as a pressure dynamics change. But that doesn't happen in everybody. So how prevalent is this? It's about 25% prevalent. So if you look around you, you look at 10 people, 2.5 of you, I don't know how I come up with half, but 2.5 of you have a PFO, just looking around the room. And people that have brought light to this and having a PFO that are regarded as celebrities and whatnot have brought light are Teddy Bruschi on the left here. This is a New England Patriots linebacker, was diagnosed with a PFO and stroke in 2006. And he was taken to surgery by our CT surgery friends, and he was closed up, and he went back to the New England Patriots only 8 months later, practicing on the field. So really impressive how they got him back out so quickly. This guy is Brett Michaels. I actually didn't know who he was. I had to look it up. But he is a Poison guitarist and a reality star that had a stroke as well as a PFO. He brought a lot of light to it, the community in general awareness of PFOs. And that was in 2011, and he also had a surgery to repair his PFO. And then this lady here has actually brought, in my opinion, the most attention to PFOs. This is Hailey Bieber. She's a model and Justin Bieber's wife, and she had a PFO and a stroke back in 2022. And she actually made a video about it online, calling it a very devastating, scary experience. And she actually had transcatheter closure through her leg, and it was successful. But the nicest thing about her is that this video has been viewed by tens of millions of people. And I think that it's been very helpful in bringing awareness to the community. So if one in every 4 of us has a PFO, what does that mean? Does that mean that we should be looking at this more vigilantly? What should we be doing, and what are the clinical significances of it? So we'll go through each of these. One of them is migraines. Another one is decompression sickness that can occur, desaturation syndromes, which we'll talk about, and of course we'll end off with the second half of the lecture being about cryptogenic strokes. So migraines with aura. So what happens here is people that have PFOs, there's these vasoactive peptides that usually, again, this is the pulmonary circulation, this is systemic circulation in a person that's an adult. Usually all these vasoactive peptides, they'll go from the right atrium, then they'll go to the right ventricle, and then they'll head over to the lungs. And the lungs actually filter all these out. What do these vasoactive peptides do? So there's one that's a calcitonin gene-related peptide. There's another one called PACAP. Those letters are not important. What they do is more important, is that they can cause vasoconstriction of your vessels. And when they constrict your vessels, that can cause migraines. They also have microemboli, which are small clots that are not visible by our gross visual examination. And these can cross over. Now you don't have the lungs kind of creating a filter. If you have a hole there and some of this blood crosses over from the right side to the left side, then what can happen is these small microemboli can actually make it to the systemic circulation, and some of them can make it to your brain. And that can cause migraines. So that's one of the clinical significant things that can happen with a PFO. Another one is called decompression sickness. So this is in people that have jobs that may cause them to go from high pressures to low pressures really dramatically. And that can be in a scuba diver, as shown in this picture here. It can be in an astronaut or an aviator. But speaking of scuba divers, so what they do is in commercial scuba divers, they breathe in heliox. And heliox is a special mixture of oxygen and helium. And what happens is when they go from this high pressure to this low pressure, and if they come up too soon, it's called the bends. And what happens is that those nitrous bubbles actually precipitate. And would this be that big of a deal if you didn't have a PFO? Well, they would precipitate in your venous system, remember the right side of your heart. And then you would kind of breathe out those nitrous bubbles. It would make its way into the lungs and you'd be able to breathe those out. But suppose those nitrous bubbles precipitate and then they make it to the systemic circulation. They make it through that little hole from the right atrium to the left atrium. They're now in the systemic circulation. And what do these nitrous bubbles do then? Well, they can actually cause an occlusion. And I can show you that a little bit better in this picture. So as we talked about before, these nitrous bubbles precipitating, they make it to the lungs. We're okay. We're going to breathe those out. If you're a scuba diver or diver. But if you have the hole here, as you can see on the right side of this picture, then it can actually cross over from the right side to the left side and make its way into your arteries. What can that do? That can actually, see this bubble all the way on the bottom right, it can actually cause an occlusion. And then you can get a mottled appearance, as you can see here in this gentleman. And that's due to occlusion. What is the treatment for that? You put them in a hyperbaric chamber. That's the treatment, but you can cause some permanent damage with it. So that's when it's also significant to have a PFO for these scuba divers that are coming up pretty quickly from a very highly compressed zone to a decompressed zone. So this is platypnea orthodeoxia syndrome. That's a mouthful. So this is when Dr. Patel earlier was talking about heart failure, and one of the signs of heart failure, and something that we go over a lot is, well, I'm not really short of breath when I'm sitting up, but I am very short of breath when I lay down, and that's orthopnea. This is the exact opposite and almost paradoxical, right? Like, so you're laying down and you're feeling pretty good, and then you sit up and all of a sudden you become short of breath. Well, when does that, why would that happen? In a person with a PFO, what would happen is you see an increase in the rise of your right atrium, the pulmonary circulation, and then you see a drop in the left atrium. And when that happens, of course, we talked about the path of least resistance. All of a sudden, you have this blood that's returning from your body that's deoxygenated blood, so dark blue blood, not with oxygen, and it kind of travels over to the left atrium. And now all of a sudden, you've sat up and your body's getting less oxygenated blood to the tissues. And now all of a sudden you're like, wait, why am I short of breath when I'm sitting up? Well, that's because you're getting that dark blue blood into your systemic circulation where it shouldn't be. It should have gone to your lungs and it should have been filled up. The lungs are kind of like a gas station where it just fills up a bunch of, fills you up, and then you're ready to go into your system. This just talks about that mechanism I just spoke about, where they, when you're moving from a decubitus position, which is laying down flat, to a standing position, your pressure increases more than your left atrial pressure. And when that happens, path of least resistance, our blood does what we tell it to. Now, the diagnosis of PFO, that can happen through two different methods here, actually three different, which we'll talk about, but these are the two most common. Is a transthoracic echocardiogram, where they put the probe on your chest and they put some gel on there, and then what you do is you take agitated saline. You take a bunch of saline and you agitate it back and forth, and we'll talk about that as well. But when you do that, you basically inject that saline into one of your veins, and of course, since it's venous flow, it's going to go to the right side of the heart. And if those bubbles cross over to the left side of your heart, as you're kind of seeing here in this picture, as you're seeing here in this picture, you're seeing those bubbles cross over, and that's a positive agitated saline study. Whereas you can also get it through a transesophageal echocardiogram, which is basically when we go down your food pipe with a probe that's about as big as your ring finger, and we take a closer look. This has a lot more sensitivity. It can rule out people that definitely don't have a PFO. So both methods, one is a little more invasive than the other. I do not believe that Eisenhower has this method. This is a transcranial Doppler where you basically take an ultrasound, put it on your middle cerebral artery, and then you inject the bubbles through the vein. This is a normal heart, which there's no bubbles crossing over. This is a PFO, and you can kind of see how does this picture look different than the other. There's a bunch of little white lines here. That's a positive study, and you can even grade how big the PFO is based off this positive study. One thing I do want to talk about with these bubble studies, what you should see when you inject that agitated saline, you should see those bubbles show up in the right atrium, and then you should see them cross over within 2 to 3 beats. If you see bubbles cross over within like 7 or 8 beats and you don't visualize them directly here and you start seeing them show up here, that means those bubbles have traveled to the right atrium, then to the right ventricle, then into your pulmonary arteries, and from there on, they've made their way to the left atrium somehow without being filtered by the lungs. And how have they done that? Because there's a shunt in your pulmonary circulation. So the timing is very important on these. You could either have an intrapulmonary shunt in which you see the bubbles way later, and when I say the bubbles, the first few bubbles way later, or you can have an intraatrial shunt, which is very important. You see it within the first 2 to 3 beats, and you actually see them directly cross. We talked about the TCD. So how do we do a successful bubble study? So you want to do an IV that's not the same. You want to get IV access in an arm that's not the same as a blood pressure cuff. You want to pull out about 8 to 9 milliliters of saline in one of your syringes. The other syringe should have 1 to 1.5 milliliters of air. You hook up a 3-way stopcock, and you really agitate back and forth. And when I say agitate, I've seen some people kind of do these agitations and they're yawning during them. It's pretty easy for them. It shouldn't be easy. You should be quite agitated while you're agitating because it's hard to do. Your thumb should be going back and forth. It's not like a fun thing to do, but you should be going back and forth and vigorously. And that is the best way to get a high quality bubble study. And then, of course, there's a maneuver called Valsalva. Once you inject, you can ask people to bear down. Why do we do this? Well, it's not the bearing down that does anything, but it's the release after they've bared down increases your right-sided pressures in relativity to your left-sided pressures. So if there was a PFO, remember the left side usually has more pressure than the right side. So by creating this Valsalva, for a momentary lapse, you're going to make the right side higher by asking somebody to bear down and release. And then you can actually see it. But only do it if they're negative. If they're positive, you don't need to do it. If you already see bubbles going across, there's no need. I think I have this video here. Let's see if it plays. Yeah, it played. So it's showing a positive study, but not a very strongly positive study, but there is a study. You see the bubbles opacify that right atrium. Here. So PFO and stroke mechanism. So how can a PFO contribute to a cryptogenic stroke? And when I say cryptogenic stroke, the first thing we want to think about is risk factors for this PFO. So although, yes, you've diagnosed a PFO and now you see the bubbles go across, but what makes a PFO even a higher risk PFO? And a lot of it has to do with anatomy. One of them is called your septum primum excursion. So septum primum and septum secundum are the two layers that are supposed to kind of close off almost like a folded curtain. But sometimes what you can have is this atrial septal aneurysm. So the area in between the heart can actually flap back and forth, making it not as stiff or solid per se. And by doing that, it puts you at a higher risk of embolization or anything from the right heart going to the left heart. The exact numbers on this, although they're not important, is 10 millimeters of excursion one way or the other past the midline, or 15 millimeters total. So when you see that this area, this wall that's supposed to keep your right and left kind of separated, if you see that kind of flapping back and forth with your hemodynamics more than 15 millimeters, that's a risk factor. Another risk factor is the larger the communication between the right and left, the larger the risks. And this can be graded by the amount of bubbles as well that we see across the intraatrial septum. So another thing is a prominent eustachian valve. So what is a eustachian valve? Well, the body has this IVC here, this inferior vena cava, that empties into the right atrium. And during what I showed you before, that fetal circulation, when that blood bypassed the right ventricle and went straight into the left, went straight into the left atrium. I think of this as almost like a ski slope or even a diving board. This actually directs the flow into the PFO. And although in fetal circulation that's much needed, sometimes it stays in adult circulation. It's completely benign, and if you don't have a PFO, it doesn't really matter much. It just kind of stays there as a prominent eustachian valve. But if you do have a PFO, and you maintain this kind of like diving board platform, or this ski slope, I like to call it, and it's actually directing flow into that PFO, into that hole. Of course, most of your blood flow will still go through the right ventricle because it'll still be the path of least resistance. But of course, this is also a risk factor. Another risk factor is a large Chiari network. What is that? That's a mesh-like structure in the right atrium that's usually harmless. Another thing that would be harmless otherwise, just like the prominent eustachian valve, both of them are harmless alone. But if you have a PFO, it can direct blood into that PFO. These are all anatomical considerations that we need to have when we have a PFO. And it'll guide our decision making later, as you'll see. A large PFO tunnel. A large PFO tunnel not only makes it a larger risk factor for causing a stroke through the PFO, but it also is harder to close PFOs when they have these large tunnels. On this right-hand side of this picture, you can see some color going through, and you can see that there is a tunnel that is elongated. It's hard to see on this picture, but yeah, it's a smaller picture. Sorry. So cryptogenic stroke. What is a cryptogenic stroke? It's basically we have no idea why this person had this stroke, despite rigorous investigation. So that's 1 to 2 months of making sure they don't have atrial fibrillation, imaging of large vessels like your carotids to make sure that there wasn't any plaque buildup that kind of flicked off or put you at a risk of having a stroke from your large vessels. And then you have to rule out how healthy is this person? How likely is it that this stroke happened from their PFO versus just age, hypertension, diabetes, smoking? All these risk factors make it less likely that the stroke occurred from a PFO. Now, as far as prevalence of cryptogenic strokes, 1/3 of ischemic strokes are cryptogenic, and 200,000 in the US yearly, 4.5 million worldwide. So they're definitely there. Now, we talked a little bit about the scoring system. This is a rope score, or risk of paradoxical embolism. What is the chance that that clot was the cause for that stroke? And the higher your number is, the more likely that stroke happened from that hole. And so people that are very young, they're going to get high numbers, right? People that are 18 to 29, even up to 49, they're going to get a +5, +4, or +3, because these people shouldn't be having strokes, right? They're young, they haven't developed that plaque yet, they don't have uncontrolled hypertension, hopefully, at that moment, and and they're more likely to have the PFO as the cause of the stroke. Now, other things. So if you don't have hypertension, you get a +1. If you don't have diabetes, you get a +1. If you don't have a history of stroke or TIA and you don't smoke, then you also get a +1. That gives you 4 points right there. All this is portending to, hey, this person's really healthy. They should not have a stroke. And if they do have a stroke, it's likely coming from that PFO. Now, the next thing you see on there is cortical infarct on imaging. This is when it becomes a little out of our league as cardiologists, so we need our friends to help us out. And that is the key of the next step, is having collaboration. That is always the foundation. With neurology and cardiology on board, if you want, you can get a hematologist on board as well if you're dealing with thrombophilia, as well as vascular surgeons if you wanted them to weigh in on this. But at the end of the day, I don't think this should be done by one specialty alone. You need your neurology friends to help you with especially that last score, that cortical infarct. Like, how likely was that from a small clot that passed over, or is it due to some other disease? And they can help us out with that answer. So this is a busy slide, just a trial timeline. The most important thing about this slide is I just wanted to point out that the first FDA approval of an occluder happened between 2016 and 2017. So the blues are all the Amplatzer PFO occluders, and the reds are the Gore Cardioform occluder device. So regardless of either of those, what you see is between 2016 and 2017 was your first approval. So it's a pretty young process here. We're only in year 9 of doing this. But it showed some, and we'll talk about these trials and how well the positive results that we've gotten from them. So this is a very busy slide and very hard to read, but I just wanted you to focus on the conclusions of the first 3 trials back in 2012, 13, and 13. This is closure, PC, and respect. It basically showed that closure of this PFO was not superior to medical therapy alone. And when we talk about medical therapy, we're thinking antiplatelets such as aspirin and Plavix versus anticoagulation. Now, the next 3 trials showed an overwhelming positive of closing the PFO, putting them on antiplatelets for a short duration of time is much superior than just going on antiplatelets alone. And the endpoint for this was usually another stroke. So that's important to remember. This is a little easier to read. Again, the first 3 showed that there was no clinical benefit. But what's important to remember here, in the RESPECT trial, there was a lot of crossover. So a lot of people had medical therapy alone, but then they crossed over into getting a PFO occluder device. And when they did, there was actually an overwhelming positive result as well. At not only the long-term follow-up in 5 years or 5 or 6 years, but also in the short-term follow-up when they did a subset analysis later. So that also showed significant benefit. And then, of course, the next 3 trials, what's important here is that the closed trial did a 1-to-1-to-1 randomization. So one group had the PFO closure, the other group had antiplatelets, and then the other group had anticoagulation. So what's better? They were trying to say, well, is it better to just be on warfarin versus aspirin and Plavix, or is it better to get the device? And let's divide it into 3 groups. It showed that the device was actually the best outcome for that. Again, that was in 2017, and then Gore reduced trial showed a significant reduction in new brain infarction as well as stroke follow-up in 3 years. And then there was a defense PFO, which showed there was only 120 patients, but it showed that with the PFO closure, there was no strokes, and with the medical therapy, it was 12.9% strokes. But again, 120 patients in that one. The big ones are the close, Gore reduce, and respect. So this just shows how rigorous we need to be when we've diagnosed somebody that's less than 60 years of age and has an ischemic stroke and a PFO. So you've diagnosed your stroke, you've diagnosed this patient as a PFO. Now, the only time you should actually be closing that PFO is when you've ruled out everything else. It is, you have to rule out large artery atherosclerosis, which we talked about with the carotids. You have to rule out a cardioembolic source, small vessel disease, which happens with, untreated hypertension as well as diabetes, arterial dissections. That's another disease you want to rule out. A hypercoagulable disorder, you want to rule that out. Once you said no to all that, you still have to move on and say, well, do they have uncontrolled hypertension or diabetes that could be the cause of the stroke? Do they have an autoimmune disease or drug or alcohol abuse that could be causing the stroke? And if you say no to all that, then you should put them on an event monitor, which we do often after patients come into the hospital with a stroke. We usually do put them on a 30-day event monitor. I prefer 60 days, just a slightly more conservative, just for that rigorous finding atrial fibrillation within 60 days. And once you can say they don't have that even, Then you can move on and say, do they have more than 1 year life expectancy? Do they have end stage heart, liver, lung, or kidney disease? Any cardiac tumors? Any heart infections? Or severe valve problems? And if you've said no to all that, then we can consider, let's do the PFO closure. And we talked about all these reasons, enhanced reasons for PFO closure. We talked about the large PFO, the atrial septal aneurysm where it's flapping back and forth. And then, of course, multifocal cerebral defects. What does that mean? That just means that there's several areas that show that there is not enough blood flow. And when they see several areas like that, they're thinking multiple small clots have crossed over, which makes it more likely that it came from a PFO, depending on the situation, of course. So when you put a device into an interventional cardiologist's hands and you have 1 in 4 people that have it, we want to be very diligent. So we created the Society of Cardiovascular Angiography and Interventions created guidelines to make sure that we're putting these closure devices in the right people. So recommendations. So this is a very busy slide as well, but the only thing you really have to pay attention to in this slide is recommendations for adults without prior PFO associated stroke. So if you have not had a PFO associated stroke, regardless if you have platypnea or orthodoxia deoxia syndrome, if you're a scuba driver and you're experiencing that sickness, if you have pulmonary hypertension and for some reason you think some of your deoxygenated blood is going over to your left and you're a little hypoxic, regardless of any of those situations, you should not be closing your PFO because you haven't had a PFO associated stroke. Now, there are some new trials that are testing this out, but right now the guidelines state do not do anything unless you've had a stroke. What about people that have had PFO associated strokes? What is the guidelines for that? Well, if they're between the ages of 18 and 60, we definitely recommend closing that. It's a strong recommendation, moderate certainty of evidence. And now if they're 60 or older, then you get into the rope score. You take a very closer look. You make sure they don't have atrial fibrillation. You go through your due diligence and make it a diagnosis of exclusion, basically. You look at your high risk anatomy as well. And that's all you have to take from this slide as well. So without prior stroke, do not close. With the prior stroke, start doing your due diligence, depending on the age. So recommendations for adults with prior PFO associated stroke. Now, percutaneous PFO versus anticoagulation. Now, this isn't aspirin and Plavix. This is like Coumadin versus a PFO closure. And the recommendations, this is very wordy, but it basically comes down to yes, you should close in patients with a prior PFO associated stroke. And now the next recommendation for our guidelines. And remember, guidelines are always just guidelines, right? They're people making recommendations, but every clinical scenario is different. And that's why we use our guidelines to help us make clinical decisions. Your answer may not be in these paragraphs, but they just help guide our decision making. But somebody that has, suppose they have a DVT or a diagnosis that causes them to clot more, a clotting disorder, but they still have a PFO associated stroke. So if they have that, the recommendation in that situation is to close the PFO, followed by keeping them on their anticoagulation, rather than just keeping them on their anticoagulation alone. There's been enough data to say we should close and keep them on the warfarin or Eliquis or Xarelto. And then, of course, recommendations for post-procedure management. So we put these discs in people, we close them up. What should we put them on afterwards? There's actually no recommendation beyond 30 days. So you definitely keep it on for 30 days. And then the society has not come up with, there's a big knowledge gap. I usually keep my patients on it for 90 days. These are the two types of closure devices that you can do transcatheter wise, and our CT friends also have a means of opening up and also closing up these PFOs. But this is a Gore cardioform septal occluder device, and this is an Abbott Amplatzer closure device. This one tends to have a little bit more PTFE, this kind of paper-like mesh material, less nitinol. This one is a little bit more metallic on the right-hand side. So for the conclusions, so a PFO is very prevalent, and thus careful patient selection is key. It must be used when associated with the cryptogenic stroke. And one third of ischemic strokes are cryptogenic strokes. And when we do our due diligence, we have to do the rope score. We have to look at the anatomy and those high risk factors, and we have to look at their age as well. And of course, collaboration is the foundation. We have to get neurology involved, cardiology, the interventional team, hematology if you would like, as well as the vascular team. And then we talked a little bit about the SKY guidelines. No prior PFO related stroke. Even if you have the symptoms of the migraine and the scuba divers that we talked about, as well as the platypnea or orthodeoxia syndrome, you can't just close for those reasons alone. You have to have a stroke in the past. I know it's kind of a bummer, but and then we talked a little bit about the interventional devices. And that is it.
Oh, no questions. Unfortunately, due to him being on Zoom, there's no way of asking questions. Okay. Oh. Or Brandon, do you want to get on there and then?
Okay, what was your question? Yours.
Just repeat the question.
How do you tell between an ASD and a patent foramen ovale?
How do you tell the difference between an ASD and a PFO?
That's a great question. So there are two imaging modalities that you can use to tell the difference. One of them is that TEE that we talked about, where we put that ultrasound probe in your food pipe, and that gives you a better evaluation, especially if you use the 3D. And I didn't get much into the ASD, but an ASD is more like this, whereas a PFO is two flaps with communication between the flaps. But an ASD is an actual hole. They have different indications for closure. You don't need to have a previous stroke to close those. You just need to show signs of your right-sided heart taking too much volume on. But the two imaging modalities to help you out with the differentiation of a PFO and an ASD is a cardiac MRI and a TEE, where we put the ultrasound down the food pipe.
Yeah.
Have you ever had a runaway device going up in a brain?
A what?
A runaway device dislodging, going through the foramen, shooting the left, going out in the brain.
Have you ever had a Renovate device go to the brain?
No, we haven't. I mean, I haven't had that in the past. It can definitely happen. I mean, there is a risk of embolization. We try to minimize that by testing the device before we let it go. We pull on it, we push on it, we put it through different hemodynamic stressors to make sure that it'll stick in place. We also try to choose the right anatomy way beforehand. We evaluate that tunnel that I showed you and how long the tunnel is. Is there that flap that goes back and forth, those 15 millimeters that we talked about? And based off your anatomy and the characterizations of your PFO, we try to make the right selection of the size of the disc that we use. And then, of course, during the procedure, we really put it through kind of a tug test. But no, haven't had it, but it is a complication that you can have.
So my son was diagnosed with a PFO about a year ago following a minor stroke. And it was closed surgically, or actually using a catheter. I'd like to know, is this a hereditary condition? Are there genetics that come into play here with this?
The question was, is a PFO a hereditary condition?
No, it is not. The fact that it's so prevalent, it is not. It's 25% of people have it. No hereditary genes involved in this.
Thank you.
Mm-hmm. Any other questions? No?
I can't believe that. What's the abbreviation PFO?
Patent foramen ovale. Anybody else? No? All right. Well, thank you, Dr. Sharma. That makes me want to get a bubble study done proactively.
No, I don't suggest going out and getting bubble studies done.
Just kidding, guys. All right. Thank you, Dr. Sharma.
All right, thank you.